All right, so this is a talk about introduction of point-of-care ultrasound and everything that you need to know about it. It is a component, an important component of what we do in emergency medicine, and we introduce this lecture so that you have some exposure to it. So we're going to talk about what is point-of-care ultrasound, also known as POCUS. What are the advantages of it, how it works, some vocabulary, and then some cases where you hopefully can see the benefit, immediate benefit of how you can apply it in the emergency department. How do we evaluate patients? Patient comes in, and the first thing you do is you do a history and a physical exam. And sometimes you know exactly what's going on there, and you're done. You don't need any kind of testing. But you don't always have that ability. Sometimes the story is a little murky, and that's where we say, all right, let's do some testing. We try to figure out exactly what testing is going to be useful, labs, EKG, imaging, and sometimes we have an answer from there. But if we need imaging, we want to look inside of the body. So what are the different ways that we can do that? Here are different characteristics of different tests, right? So X-ray. X-ray is portable. It's fairly safe, low on the radiation scale. You can easily reproduce it. It's not that difficult to send a patient for repeat X-ray. It's not dynamic. The idea is it's a static test. It's one single moment in time. You're not getting any motion. You're not getting a look at what's going on over time. Fairly inexpensive, and the image quality is pretty good, but it depends what it is you're looking for. CAT scan is less so. It's less portable. There's more radiation. It's harder to re-image. It's also not dynamic, single moment at a time. It's not inexpensive, but the image quality is much better. MRI has a couple more advantages. It is safer in that there's no ionizing radiation, and the image quality can be even better. But what about ultrasound? Ultrasound is completely portable. You bring it right to the bedside. It is safe. There's no known risk of having an ultrasound done. Very easily reproducible. It is dynamic. You can see things moving. You can see things happen over time. It is inexpensive, and the only variable there is the image quality. And that's where you come in. People always talk about ultrasound as operator dependent. Well, everything's operator dependent to a certain extent. The quality is dependent on who is interpreting the images. In this case, it's also dependent on who is acquiring the images. Point-of-care ultrasound has other names. Limited ultrasound, focused bedside ultrasound, emergency ultrasound, clinician-performed ultrasound. And the idea is it's performed in a clinical context to answer one specific question in time. There are three components, of course. There's image acquisition, so getting the pictures, acquisition, interpretation, figuring out what the pictures mean, and then incorporating the findings into patient care, the clinical integration of your findings. And they're all done by the same person. So point-of-care ultrasound is different from comprehensive ultrasound, which is the standard one that we always think about with comprehensive ultrasound. What happens there? I am the emergency physician, and I wonder if this person has gallstones, let's say. Okay, so I go in and I order a test. I say, let's do right upper quadrant ultrasound. A tech performs it who doesn't have as much clinical experience, and they perform it, and they don't know the patient history. And so they send those pictures over to a radiologist, who then reads it and then sends it back to me. And I say, oh, I see, gallstones. Okay, maybe I should call surgery. So that takes some time. There are a couple of drawbacks, right? It's time consuming. That might be a 3-hour process. There's loss of information at each step because the clinical integration is not done by the same group who's doing the actual test. And it gives you extraneous information. If you order a right upper quadrant ultrasound just with the question of are there gallstones, they're still having somebody's looking at their kidneys and their pancreas and their liver and every lobe of the liver. And I might not have those clinical questions, but when I order the test, all of those bits and pieces of information fall in there. Point-of-care ultrasound, the doctor is the tech, is the radiologist. It is a single dichotomous yes or no question. I do not want an entire evaluation of the abdomen. I just want to know, does this patient have gallstones or not, or cholecystitis or something? It gives you focused information, and it has some benefits. It's immediate. I can have it done in seconds. You come in and I just look, oh, look at that, you've got gallstones, let me call surgery. Because the other benefit is I can clinically correlate because I've examined the patient. I have my pre-test suspicion of disease, and I can then incorporate the ultrasound findings. There are a lot of other places that point-of-care ultrasound is used. Pre-hospital, so in an ambulance, should I take this person to the trauma center? Do they have significant injury? Should I take them to the closest hospital? In the wilderness or / rural area, anytime where formal help and additional imaging is difficult. In developing countries, this I think is the greatest application of point-of-care ultrasound. There are countries in Africa where there's one CAT scanner and there's nobody to run that machine, and patients are 2 days away from the closest hospital. Whereas when you can bring the point-of-care ultrasound to the bedside, it's amazing. They've taken this to outer space. I'm not sure exactly what they're doing with it there, but it's been in the space station. And in medical schools, I don't know how much training you guys get other than this lecture in point-of-care ultrasound, but there are medical schools where when you get your acceptance letter, it says, welcome, here, congratulations, you've been accepted, here's your ultrasound machine. And you get an ultrasound machine to use for 4 years. And you learn that. When you learn basic anatomy in first year, you're learning how to ultrasound all the anatomy, and you're getting the sono orientation. And then when you're learning how to do physical exam and listen to murmurs and palpate a spleen, you're learning how to assess for that with ultrasound. And then in your clinical rotations, every rotation, you're using your own ultrasound machine, and you're figuring out how it's used in that specialty. And then you graduate from medical school with all those skills, no matter what field you're going into. It's kind of awesome, and is the future. Isn't that for radiologists? When I tell people that I do ultrasound, they say, wow, you're a radiologist? That's kind of neat. Well, that's kind of this conception, or this misconception really. For decades, cardiology, OB, and other fields have been using point-of-care ultrasound. In fact, in '99, which was almost 20 years ago, the American Medical Association passed a resolution which said, ultrasound is within the scope of practice of all appropriately trained physicians. And then it left the training to each specialty. So this is not something that is owned by any specialty. As early as 2001, the American Institute of Ultrasound and Medicine created a section of emergency ultrasound, which is now kind of been integrated with critical care. And emergency medicine is really the leader in POCUS education, research, dissemination of that information. There are a lot of other fields that have caught on and recognize its value, and every year there are even more. In fact, you might know this paper from, I think it's probably around 2010-ish or something, maybe 2011. New England Journal of Medicine, Chris Moore from Yale. Here's a nice table. Almost every single specialty that you could think of, there's some application of point-of-care ultrasound here. And so it's really kind of supporting the idea that this is for everybody, and no matter what you're going into, there's some role of it. Okay, let's talk a little bit about how it works. You have an ultrasound machine. It sends a little electronic spark to a probe. There's a crystal at the end, and that crystal vibrates. It sends out a signal, it comes back, and the machine draws something, right? And so the way it works is that those crystals have something called a piezoelectric property, which means that electricity is turned into vibration and sound. Now this one here, the signal goes out, and the object it strikes is closer. And so the machine knows that there's something closer. And you can also see that there's a difference in brightness. So the strength of the returning signal also affects how the machine interprets that. So it turns the time into depth, and it turns the strength into brightness. And so one of those crystals, you'll get like this. It sends out a little pulse of signals, boop, and then the stuff that comes back quickly is from the near field, and the stuff that takes longer to come back is from the middle. The stuff that takes really long to come back is from the deep field. And so your time equals depth, and the strength equals brightness, and every crystal does that. And then you line up all those crystals, and you actually generate an image of what's going on inside the body. Now, it does it so quickly that we can't even tell. This is happening on the microsecond level. And so it looks like real time. And this is a picture. Okay, there are a couple terms that you should know because you guys will be doing some ultrasound in the emergency department. And the more of these terms that you can throw in there, the more of an expert you'll sound like. People will be like, oh my God, how do you know exactly what you're doing? And all you have to do is just change a couple words that you know. So echogenic is anything that creates an echo. So you can see here, for example, this gallstone is very bright, and it's echogenic. It's creating echoes which are returning back to the probe. Anechoic means there are no echoes. So the gallbladder in here, there are no echoes coming from there, and the machine makes that black. Hypo, iso, and hyperechoic are relative terms, and so you use them relating to surrounding structures. You can say the liver here is hyperechoic if you compare it to the gallbladder, but it's hypoechoic if you compare it to the gallstone. All right? So if you start using those terms, instead of saying black, white, greater than, brighter than, you'll sound brilliant. Okay. Machines, to me, you look at one of those and they're very intimidating. There are multiple different buttons and you don't know exactly what to do. Get that fear out of your system. It's not as hard. So you only really need a couple things. You need power. Every machine's got the universal symbol for power, which is a circle with a line through it. Power. Turn the machine on. You need to, and then the rest of it is taking pretty pictures. And it's the same concept as with your camera, right? You want to play with the depth, so you don't want to be too zoomed out. You don't want to be too zoomed in. You want to show the structure of interest and some surrounding tissue. And then you want to look at the gain. And gain is a fancy word for brightness. Image is too dark, just say, oh, can you turn the gain up a little bit? Again, you'll sound brilliant. That's about it. That and knowing how to change the transducer is all that you're going to need to take some pretty pictures. Okay, so there's standard probe orientation. And what you'll see is the probe marker. On the top of every ultrasound image, there's something. Sometimes it's a dot, sometimes it's a letter, sometimes it's a shape, but it's only on one side of the screen. That you want to keep on, that's usually on the screen's left. And that's going to correlate to something. You can see right here, there's a little dot here. And if you're not sure, put a little bit of gel, and you'll see that only one side of the probe lights up. That tells you that this side of the probe correlates with this side of the screen. Generally speaking, we want to keep the probe to the patient's head, and this is the sagittal orientation. What we're doing here is we're using a two-dimensional plane to image three-dimensional structures, right? And so we're kind of fanning through, and there are all sorts of different ways to do that. But here, this is sagittal orientation. This is a transverse orientation, where it's kind of you're slicing through this way, and you get an image that looks like a CAT scan. And this is a coronal plane, and the image didn't play, but essentially here we're scanning in the plane of the face. And just understanding those different planes and how it correlates to what you see on the screen is kind of all you need to know. All right, so that's basically how ultrasound works, and we're going to go through a couple cases of how it can be used. 24-year-old male with motor vehicle accident comes in with belly pain. He's hypotensive, he's tachycardic. If you see this, you guys know what this is? Yeah, all right, positive free fluid Murphy sign. So this looks very different than this. In this case, you know he's hypotensive, he's got fluid in the belly, he's tachycardic, he's going to need to go to the operating room. In this particular case, it's different. There's no fluid in the belly. Doesn't mean that there's nothing there, but this person you might want to stabilize and get a CT because maybe he's hypotensive for a different reason. Okay, so this is the FAST. FAST stands for Focus Assessment with Sonography and Trauma. It is a somewhat vague term because it is used to mean fluid in the belly, but it could also mean pneumothorax, fluid around the heart, hemothorax. All of those things are incorporated into the focus assessment with sonography and trauma. Best to think about this, is there, in this particular case, is there abdominal free fluid or not? Okay, what about this patient? She's 44, she's short of breath, she comes in with dyspnea exertion, also hypotensive, tachycardic. What do you guys see here? Right, so this is a rib, this is a rib, this is the pleural line. And what we're not seeing is lung sliding. This is lung sliding. And you can see here, this lung is moving back and forth, back and forth. This means that the lung is completely inflated and is touching that parietal pleura. Whereas here, the lung is down here, and you can't see it because there's this thin layer of air, or maybe a big layer of air. When you have a pneumothorax, you can't see the lung sliding. Now, this patient who's tachycardic and hypotensive with the pneumothorax, what does she have? Tension, right? It's a tension pneumothorax. And so you know immediately, just from the ultrasound, that you should decompress the chest. Don't need to wait for an x-ray. Don't even need to auscultate, really. 18-year-old male stabbed to the chest with a butcher knife. He's hypotensive, 70 or 40, and he's tachycardic. And the question is, what are we going to do with him? So this is his heart. Left ventricle, right ventricle, left atrium. And compare that to this one. What's the difference here?
Pericardial effusion.
Right, good. Pericardial effusion right here. That is causing collapse of the right ventricle and tamponade. What do you do with this patient? Yeah, but that's a temporizing measure, right? He was just stabbed. He's got a cardiac injury. He needs to go right to the operating room. This case was actually awesome. This guy rolled in. He was on the EMS stretcher. He had this injury, and I put the probe on. The surgery attending was already in the room, and I said, "Hey, do you see this?" And he's like, "Yep, let's book the OR." He made it to the OR within 5 minutes of arriving into the emergency department. And I don't actually think he ever made it onto a stretcher, because we had the answer. He was still on the EMS stretcher. And so right there, everybody knows this guy needs to go to the operating room. There's an old study, one of the first ones that showed that. It was a retrospect study, but it was one of the first ones that showed the value. And they looked at all comers with penetrating trauma. If they had an ultrasound, their survival was 100%, whereas if they didn't, it was 57%, I think. And the difference of time to OR was a 45-minute difference. That's it. So the group that didn't have the ultrasound, they took them 45 minutes, they made it to the OR. Almost half of them died because of that. This will totally save lives. Okay, 82-year-old female with shortness of breath, altered mental status, hypotension. She's also hypotensive. And what do you see here? Right, the squeeze is terrible, right? This right here is normal squeeze. You don't have to learn any ultrasound to appreciate that there's a difference here. And that's part of one of its beauties. It's a visual thing. Everybody can look and see, I know that this is left ventricle, and this doesn't feel quite right. These walls should be moving in. These walls should be thickening. This mitral valve should be moving all the way up like it is here. And so there's a big difference. And right here, you can determine she's in cardiogenic shock. You can decide to start dobutamine. You can decide that fluids in this lady might not be the right answer, because look at her ejection fraction. She might not be able to take it, and you'll flood her lungs. 67-year-old male smoker comes in with belly pain. It's hypotensive tachycardia. You'll notice a theme: hypotension, tachycardia. The sick patients are the ones where ultrasound has the greatest benefit. And it's hypotension and dyspnea where I think you can really make a difference. What's this? No, not dissection. Right, this is a AAA. Different disease processes, right? Remember that. Don't confuse those, because the risk factors are different and the presentation is different. This is a AAA. So this person has an 8-centimeter AAA, as opposed to what you see on the right is a normal size aorta. Somebody who's hypotensive and tachycardic with that aorta, you know right at time zero that your efforts should be focused at getting him to the operating room. Now, caveat, don't forget, people with AAAs can also have things like sepsis. And someone might have a long-standing aneurysm, and it's 4.5 centimeters. So don't forget but it's not the cause, it hasn't ruptured. It's not the cause. In someone like this, 8 centimeters, that's really big, right? Over 5, you're really concerned. But don't forget, ask for things like, have you had a fever? Maybe consider giving antibiotics so they don't die of sepsis in the OR from a non-ruptured AAA. Most of the time, you're going to try to stabilize these patients to get them to CAT scan anyway. That definitely helps the surgeons with their surgical planning, but you don't always have that luxury, and so that's where ultrasound can really make a difference. Okay, 26-year-old female, 8 weeks pregnant. She's got pain and some vaginal bleeding. Also, hypotensive, tachycardic. And so what do you guys see here? What's the difference? Many differences, actually. This right here, you'll see, this is a transvaginal ultrasound.
Pregnancy.
Right, this is intrauterine pregnancy. Right here, you can see there is a little yolk sac nomenclature. The black circle, the house, that's the gestational sac. The white circle, that's the yolk sac. You'll always see yolk sac or fetus and then a fetal heart rate until the baby's born. So you're looking for yolk sac. That's the first sign of a definite IUP. For ectopic pregnancies, the approach is a little different than most of the other ultrasound. We're not really ruling out ectopic pregnancy. It is hard to do a complete evaluation, and you can't always see it with ultrasound. So what we're doing is we're ruling in an intrauterine pregnancy, and then assuming that the patient doesn't have a heterotopic pregnancy. Does that make sense? If they have any history of in vitro fertilization, or if they had embryos implanted or anything, then you kind of have to worry about, could there be a heterotopic pregnancy? So anybody with IVF, looking and seeing an IUP isn't enough to rule out a heterotopic pregnancy. But in most patients, it is. And so in this particular case, she's 8 weeks pregnant. We would expect to see something. We don't see anything. We just see an endometrial lining here. In fact, we see a little bit of something out here. So sometimes you can actually see an ectopic pregnancy. That's not the goal. The goal here is to identify an intrauterine pregnancy and then assume that it's not a heterotopic. Okay, 40-year-old female, motor vehicle accident. She has some trouble breathing. Hypotensive. And what do you see here? Right. This is the right upper quadrant. Remember we saw this with Morrison's pouch? So we're just looking a little higher now. And this is diaphragm coming down here. This is spine. And this here is dark, anechoic. And that tells me that it's fluid. Fluid above the diaphragm in the setting of trauma is what? Hemothorax. People forget about this. People forget about routinely assessing for hemothorax. Right? You can absolutely determine this is a hemothorax. It blows away chest x-ray as far as sensitivity and has similar specificity. On this side, you can see normal. You can see the same diaphragm and you see the spine here, but you don't see anything to the left here. You don't see any spine. It's wiping it away. Right? This is a normal lung. And you can comfortably say there's no reason to do a chest tube here. Somebody comes in hypotensive. The standard used to be put in immediate bilateral chest tubes because maybe let's just make sure it's not a hemothorax. Let's make sure it's not a tension pneumothorax. And you can completely do away with that if you're good at ultrasound. You can say, no, don't bother doing that. There's no fluid, no reason for that. The other reason that this is helpful is when the patient's going to need the operating room, you can tell the surgery team, hey, you can tell them if they need a laparotomy or a thoracotomy. You can tell them what they should start with, because if they get that part right first, then the patient has a better chance of surviving. Pleural effusions look exactly the same. You might just have a dyspneic patient with no trauma, and when you see that, you can figure out that they have pleural effusion and why they're having the symptoms. Okay, 50-year-old female, right upper quadrant pain, nausea, vomiting. Compare these two ultrasounds. What do you see here on the left? Multiple gallstones. This is the example from earlier. Immediately, right here, I know that she has gallstones, as opposed to here, when you don't see gallstones, you can then say, well, let me consider additional workup. Let me check your LFTs. Maybe I'm going to do a CAT scan instead. Right? In this one, you say, aha, your pain is from cholelithiasis. Maybe I'll do some labs, make sure that you're comfortable and not having any other signs of cholecystitis, as you see a thin wall here. And you can figure out right away what's causing a patient's pain. 6-year-old male with leg pain and edema. What's this? We're in the groin, femoral artery, femoral vein. You guys see some echogenicity within the lumen? Right? That's not normal. Veins should be filled with blood. Blood is fluid. Fluid is anechoic. You should see no echoes from inside. You should see this. No echoes. And when I compress, see this? Watch it. Compress, squish it, goes away completely. This is a patent vein. This one is not. Immediately at the bedside, we know this person has a DVT. You're done, really. You can just start treating right there and say you've got a DVT. All right, this patient's got dyspnea exertion, had hip surgery a week ago. The clinical stories aren't always that slam dunk, which is why ultrasound is really helpful. And what do we see here? Yeah, good. So this is the heart. This is the right side. This is a parasternal short view. Left side, right side. The right side looks pretty big here. And it's squishing the septum. See that? That's called septal bowing. That's a sign of elevated right heart pressures. This is the apical foreview. This is the left side. This is the right side. The right side is bigger. It should look like this. It should look like the left ventricle is round and circular the entire time, the septum's not squished in. Here the left side is bigger than the right as normal. You're never going to rule out a pulmonary embolism with ultrasound. But when somebody comes in with dyspnea exertion and let's say no other cardiac history, and you see there's a decent, you're pretty much done. You know right now that not only does this person probably have a pulmonary embolism, it's a big one because it's causing right heart strain. Not all PEs cause any right heart strain. You can have big PEs with no right heart strain. So we're not going to rule it out. What's another thing you can do to this patient if you're not sure? Let's say you're really worried about a PE and normal looking heart. What else can you do? Yeah, right. Well, that's a good point. There are other ways to assess. There are other ways to assess the right ventricle, such as TAPSE, but you could also look elsewhere. You can look at the legs and find a DVT. DVT plus shortness of breath equals PE. A 25-year-old drug user, pain and redness to her left arm. Might be nothing. It could be this. What's this? Right, good. So there are a couple of ways you know it's abscess. One of them is that the word abscess is written right here, which is always a helpful clue. So look beyond just the picture. But yeah, this is called a positive squish sign. So you're looking for a fluid collection. This is soft tissue ultrasound. We're looking for fluid collection. And when we squish like that, you can actually see that there's mobile material here. That tells me if I cut, then I'm going to get something coming out. This also is actually a vein. This is the antecubital fossa. That's the vein. And so it tells me I don't want to cut here. I want to cut over here. Right? So it can guide your procedure also. As opposed to this. This is called cobblestoning and is seen with any kind of edema. Now, if you have redness and suspicion, clinical suspicion of infection, and that's cellulitis. It's not specific for cellulitis, though. Anybody who comes in with CHF, big swollen legs, take a look and you'll see this kind of cobblestoning. This just means fluid within the soft tissue. And the real value of ultrasound here is to assess for a fluid collection that you need to drain, as opposed to not. So the cellulitis is not an ultrasound determination. It's a clinical determination. And we're mostly doing it to rule out an abscess. Okay, what about a 36-year-old guy presents with right flank pain, nausea and vomiting, and he's got this here. This is his kidney. Hydro, right, hydronephrosis. This tells me right here that he's got some signs of obstruction. You can see as opposed to here, no signs of obstruction. So signs of obstruction of the right kidney with flank pain is likely to be a stone. There's a nice role of ultrasound for evaluation of renal colic because in many cases, this is a group of patients that get so many CTs over the course of their lives. And any time, any opportunity you have to reduce to save a CAT scan is helpful to the patient. So let's just say this patient had a history of kidney stones. This feels just like my kidney stones. I see some hydro here. Okay, let's not do a CAT scan because it's not going to add value for me. I know you have the likelihood that this is from kidney stone is very high. I'm going to treat you symptomatically, and if that patient does well and feels much better, you can send him home without a CAT scan. 6-year-old male, nausea, epigastric pain, fever, right lower quadrant tenderness. What's this? Yeah, good. So this is appendicitis. This is an inflamed appendix. You can actually see an appendicular. And this is kind of nice because you see that this is the abdominal wall. This is the peritoneum here. You see how this inflamed appendix is touching that peritoneum, right? That's why you get the focal tenderness. This is why you get the migratory pain, because usually the appendix is a little deeper, and when it first gets inflamed, it's touching all the bowel, and you get this visceral irritation, which causes the periumbilical pain. Once it touches the peritoneum, you get that localization, and so you have that classic migratory periumbilical tenderness. Now it's in the right lower quadrant, and it's because of this. This is another great group of patients to save a CAT scan in, and especially in pediatrics, where every CAT scan has a higher effect. Anytime you can save a CAT scan is going to be great. So right here, you can say you've got appendicitis, call surgery, admit. Okay, 18-year-old splinter in her finger. So here you can actually diagnose exactly where a splinter is. This is a water bath technique. You guys ever seen this? You fill up a basin with water and you just have them put their hand there. The probe is not even touching it. The probe is 2 centimeters floating above her, right? Which is great because when they have a painful digit, it hurts when you're pushing on it. And so you can actually localize where the foreign body is, so confirm that there is a foreign body, and then guide your procedure. So here's a needle, and we're going in, and we're going to be do some hydrodissection here and inject some lidocaine right to that area to kind of loosen it up, and then you can help localize the foreign body. So for foreign body removal, again, for procedural guidance, ultrasound is great. 88, this is my favorite, 88-year-old female with history of CHF, COPD. She's really tachypnic, she's tripoding, she's hypoxic, she's wheezing. And you don't know, is this cardiac wheezing from bad pulmonary edema? Is this COPD? And the nurse says, doctor, do you want me to start diuretics or do you want me to give her some nebulizers? And you don't know. How do you know? You hear wheezing. And you want to guess right because you'd prefer to not give beta agonism to somebody in pulmonary edema. You'd prefer to not diurese somebody with bad COPD. So you look at their lungs. This is the pleural line. These are called B lines, and they signify pulmonary edema. This is a normal lung, and this is the pleural line. And you see these parallel horizontal lines. Those are called A lines. Those are normal. We would all have A lines right now. In the setting of shortness of breath with A lines, you got to think asthma, you got to think COPD, maybe even a pulmonary embolism, right? Very different than what you see on the left, which is B lines, which would most likely be pulmonary edema, can also be seen in pneumonia. Lung ultrasound, I could talk for hours about lung ultrasound because it's the best. But right here, you can immediately determine how am I going to be treating this patient the best way. Okay, and you have last case. Famous sumo wrestler gets unconscious after 2 rounds. He's hypotensive. He's got no IV access. What do you want to do? You're going to just go stick in a big needle into his neck? Well, why? Why would you do that if you can use ultrasound? And so for procedural guidance, for vascular access, for peripheral IVs also, knowing how to use ultrasound to guide those procedures. Here you can see needle inside the vein. And now you've got access and you save them and you're not going to be the embarrassing doctor who let the sumo wrestler die. Okay, so how to use ultrasound properly. It is great for ruling in or ruling out pathology, but you have to know which. You have to know how to use every one of those findings in the clinical context. There is no risk to putting a probe on the patient. I encourage you to do that as often as you can. There is, or there may be a risk in making decisions based on your own ultrasound. And that's why we have it takes time to learn ultrasound. It takes a lot of practice. But you're not going to ever have the opportunity to make a decision if you don't look. If you're going to make a decision, err on the side of caution. In your case, of course, do it together with the residents and attendings that are supervising you. Learn the skill. No matter what you're going into, learn the skill. There is a valuable role of point-of-care ultrasound. Think of opportunities to use ultrasound when you see a patient. And I encourage you guys on your rotation to be, after you see a patient, evaluate a patient, just say, hey, I was thinking we should do a point of care ultrasound, or go in there and do it before you even present the patient. People will love that. Whenever you're getting a confirmatory study, that's a nice opportunity to get an ultrasound. Anybody getting a belly CT, go ahead, take a look. Look at their kidneys, look at their gallbladder, look at their aorta, see what you can figure out, do a fast exam on them, and then correlate what you saw with the CAT scan. And you'd be like, oh, yeah, I was right. I said there's no hydronephrosis, and it said there's no free fluid, and I thought I saw gallstones, and the patient's got gallstones. Learn from the mistakes. When you say, I thought that was fluid, it turns out it was just bowel. Go back and look at the pictures. You can teach yourself ultrasound by doing imaging, and the best time is when there's some confirmatory study. Somebody's going for an echo, do your own echo. Write it down. Look it up later. If you learn this skill, you will save time, you will save radiation, save money, and save lives. And that's kind of why we all went into this in the first place.